Welcome to the Voices of Healthcare Equity. I'm Kim Tranquata, the founder and CEO of the Healthcare Alliance for an Equitable World, and your host on this journey. Our organization, driven by clinicians, is on a mission to address global healthcare inequity using telehealth solutions. Together, we're building a community of healthcare professionals committed to making a scalable impact on global equity. Join me in insightful conversations with health innovators around the world as we explore the current and future state of healthcare. Be a part of the mission. Let's create lasting change together. Today, I have the great pleasure of speaking with Eloisa Perard. Eloisa is the president and CEO of Gracelight Community Health, a nonprofit, federally qualified community health center dedicated to advancing equitable healthcare access for underserved communities across Los Angeles. She's a longtime resident of Los Angeles, California, and holds a Bachelor of Science degree in Business and Leadership and a Master of Science in Organizational Psychology, one of my favorite topics. She serves on the board of directors and finance committee for Healthcare LA, an independent physician association, and she is a member of the Chicago School Board of Trustees. Boy, another organization about to go through big changes. Yikes. And serves on the board of directors for the California Primary Care Association. I'm so grateful for you making time and doing all this wonderful work, and I can't wait to have this conversation with you and find out what's going on. I do want to give you the opportunity before we start chatting away to identify any conflicts of interest or affiliate disclaimers that you'd like to have.
No, I don't think we need to. I'm speaking on behalf of myself, Eloisa, but also as the leader of Gracelight Community Health and, healthcare industry in general.
Awesome.
Yeah.
Well, let's go about it. Tell us a little bit about you. Who is Eloisa, your background, and how did you become involved in healthcare equity and running this organization, Gracelight?
Well, first of all, I want to say about your intro, I love be a part of the mission. Yes, we all need to be a part of the mission. Absolutely love that. Thanks for having me on. I'm a native Angelino. I was born and raised in Los Angeles. My parents, proudly Mexican-American immigrants. My journey into healthcare was not traditional, right? I didn't grow up thinking I'm going to be in the healthcare sector, but it is deeply personal because of my background, right? I was a teen mom. I was raising my son while I was trying to work. It took me 8 years to get an undergraduate degree, right? I was at the School of Hard Knocks. I put myself through school like so many others in my community. And so I relied on public health to help me move forward. Early in my career, I spent a lot of years in human resources, which, growing up in HR gives you a unique perspective it gives you like a front row seat to different systems and structures that impact people's lives at work. And so about 8 years ago, I had the opportunity to join Gracelight as the vice president of HR. From there, I was appointed chief administrative officer, and then I became president, and now I serve as its CEO. I'd say that my lived experience really informs everything I do because I know what it's like to navigate life without a safety net. And so it makes me very passionate about building systems of care that are accessible, that are compassionate, and that are rooted in dignity. And, I'll share a real quick story about when I was a teen mom and I brought my son in to see his pediatrician. I always felt like he really cared not just about treating my son, but about helping me as a teen mom navigate my way in such a difficult system. And that personal attention he gave me and my son meant everything to me.
Wow, that is an amazing story. And thank you, Eloisa. It really makes me think, there are people that that come from difficult circumstances. Everybody has some difficulty that they experience in the course of their lives. And some people come out on the other end of that with a great inspiration and aspiration to share that forward with others. And then others come out of it, I think, a little bit angry and maybe even wanting to make others go through the same or punish them or something. I don't know. It's not me, so it's hard to imagine, but you feel it. I think we're in a time where we're especially feeling it. And so I'm curious. I hear your story. Look, I have a similar story. I'm a immigrant kid. I come from, I come from what was a very undeveloped country in Guyana, South America, and moved to the Bronx when I was a little girl, grew up in the South Bronx. I mean, we had nothing. We didn't access healthcare because we couldn't afford it, period. End of conversation. And I think the story you tell about your pediatrician is part of the key. It's the being treated kindly by somebody when you're in those moments and finding inspiration to bring that forward and bring that kindness to others, I think is the key. Like, I struggle sometimes. I'm like, I want to make a great big global impact, but I think the impact is one person at a time carrying that forward. I don't know, Eloisa, what do you think? I think I'm just rambling here.
No, it really is. And wow, thank you for sharing your story. You know, just a few years ago, I went to this pediatrician's retirement party, and it's funny how we always think we're alone, like it's our struggle and others can't possibly understand what we're going through. And when I showed up, his name is Dr. Oyamati, and he was just a brilliant physician, a pediatrician that touched so many lives. There were so many women there with their adult children. Me too. My son is 27 now. At the time, he was 25. But there were so many adult women there who shared that I was a teen mom and Dr. Oyamati helped me. And some of them would say, he delivered food to my church when I told him we were really struggling. And the amount of effort and personal sacrifice that he made to help so many of us, I was so inspired by what he had done and all of the lives in that room that I saw that he touched. And it's just a blessing to be able to pay that forward in that way.
Indeed. I really think the secret to, I'm going big here, to world peace and prosperity is for people to feel that dignity and respect in the moments where they're the most vulnerable. That is the pivotal moment between people becoming inspirational, aspirational givers in society or angry destroyers of the system, so to speak.
I agree. I can imagine in this case with Dr. Oyamati that he had the day-to-day frustrations like everybody else of, physicians are really going through a hard time, right? Provider productivity and the burnout and all that he felt. But to be there in that moment and be celebrated and see all the lives he had touched over all those years, and I think I reflect on that journey myself, doing the work that we're doing at Gracelight. It's challenging and you're often, you come in with all these good intentions, but earlier you talked about not letting the system turn you cynical of sorts, right? Like pessimistic, and how much you have to remind yourself about the lives that you can touch and transform. And I don't know if I'd be where I am today if I hadn't had access to these resources. And so it's a good reminder.
Yeah, beautiful story. Thank you for starting with that. So tell us a little bit about your organization. So I think it's important that we kind of do maybe a little bit of educational primer. What is a federally qualified community health center? Why is it different than any other clinic? And what does it mean for your mission now? And And what does it mean for your longevity in these times? That's a lot. I'm sorry. Let's reel that back.
So that's okay. Yeah, no. Let's start with I remember the first question. Tell us about federally qualified health centers. So we can start there. Um, so Gracelight Community Health is a federally qualified health center, and short FQHC. And what that means is that we receive funding from the federal government in order to provide primary care to the community and other types of care. Most of our patients are Medi-Cal recipients or uninsured or underinsured, and we never turn anybody away regardless of their ability to pay. So everybody will receive care. It'll be culturally competent care, meaning our providers speak their language, our staff speak their language, right? And the Medi-Cal is primarily who our patients, the insurance that they have. How we're different is that we're directed by a board of directors who is made up of 51% consumer members. That means patients. So my board of directors is made up of 51% of my patients. And it makes the environment unique because we're really paying attention to what's happening in the community. And we're really making decisions about the care we deliver based on the actual patient's perspective, right? And driving our mission to meet the needs of Los Angeles. So I had never heard of FQHCs before I came to Gracelight, and I think it's as close as you get to universal healthcare. We never turn people away. It's a brilliant model. They really do scrutinize the care we give in terms of the quality and the outcomes. And so at Gracelight, we've won awards every year for quality outcomes. And it's different than your other clinics because they're not held to the same standard of quality and patient outcomes that we are. And so it's an incredible benefit to be a HRSA grantee, which is the federal system HRSA grantee. And there are a lot of things we have to do to live up to that agreement.
So a lot of golden things you just said. Imagine if every healthcare system had a 51% patient board of directors. I say that's an improvement we need to make across the board. So you did mention that, and that really keeps the work that you do grounded in the patient's stories and lives and relevance to the patient and not necessarily relevance to the business or the board of directors, which we see a lot in our healthcare system. But then the fact that the federal government subsidizes this care because you are providing care to people that can't go to a private clinic because they don't have medical care. And I'll say it, but you can add on to that. Some people might say, why is that important? That's important because no care is always more expensive than giving people care at the front end before they get very sick, right? So treating somebody before they're critically ill is, first of all, human-wise, it's just better for people, right? And it's that thing we talked about, is that affirming people's potential and dignity when they feel the most vulnerable, that makes the future and our communities safer and better, number two. And then number three, somebody has to take care of folks that the system that we have allowed to be, free market system is very, very expensive, period, in a conversation. Any other why is that important you would want to add to that?
Yeah, I'd say that, something additional about FQHCs is that they were brought about by Dr. Jack Geiger, who had the vision for FQHCs. And what he really What he really wanted to see in the world was a healthcare system that was exactly what you just said, right? It wasn't about reacting to the illnesses people brought to the table. And he used this example about it's not about pulling the baby out of the water, right, and helping the baby thrive, but about going upstream to find out why the babies are landing in the water in the first time and stopping that from happening in the first place. So, another thing that's pretty unique and was part of Dr. Geiger's vision was that it's not just about the primary care we deliver in our health centers. We're a community of other nonprofit organizations, other community collaborators that really form a safety net around the community. So we help with housing navigation services, food insecurity, right? They can come to us not just to see their doctor, but for everything that they have needs, right? And we'll connect them to these community supports. And so it really is wonderful to be part of such a deep safety net.
That part is so key, the coordination of services and benefits. So the United States has a market-based healthcare system where people, and I'll use people as a plural, right? The individual purchases insurance, but insurance is paying some of healthcare, you're paying insurance. It's based on anyway, it's all very transactional, right? There's money flowing in lots of different ways. And so there's only one part of the U.S. healthcare system that anybody can go to and get care without having to prove that they can pay or that they have insurance. And that's emergency rooms all around the country because of a law called EMTALA, the Emergency Medical Treatment and Stabilization Act, right? And Active Labor Act. So that law was to keep hospitals from kind of dumping their patients and saying, hey, you can't pay, you should go to the one hospital down the street that actually sees uninsured patients, which was unsafe because they would do it with unstable people. But what we find in the emergency room, where I'm proud to have worked my whole career because I get to take care of everybody, and that's the kind of work I want to do, is that we do see patients, right, with a medical illness, and you can't treat their medical illness unless you can address the other parts, their housing, whether they're abusing substances, whether they have care. I see people all the time. I mean, complex medical conditions, they have cancer and they got a blood clot, but they can't travel to the tertiary center that's 2 hours away to get that care. And at home, they don't have a home. So how do you call them to make appointments and arrange the services? It's a total mess and you can't care for people. And I want to say to people out in the world, look, when you have members of your society that you cannot care for, it is everybody's problem. Diseases become a problem. Crime becomes a problem. You don't like, everybody's got the NIMBY thing, not in my backyard. You don't want the housing encampment in your backyard. No, those people don't want to live that way. They are doing what they have to do to survive. So we have to have some mechanisms to take care of these things on a much bigger system, on a much bigger scale. I love what you're doing, and that the folks in those communities can go and take care of a holistic approach to health and well-being. But what about the people that can't, right? It really needs to be for everybody. So I love that what you say, where, you have all the services to really coordinate that.
Yeah, in the communities we serve at Gracelight, some of the most persistent equity challenges are tied directly to those social determinants you just talked about. And they're not buzzwords. These are the daily realities that shape people's abilities to live healthy lives, right? We see so many high rates of diabetes, hypertension, which are often driven by an inability to access healthy food. Los Angeles is a food desert, so people are working, unable to go cook healthy food. They don't make the time for it because they're exhausted, right? So fast food is easy and fresh, affordable food isn't. So managing a chronic condition is hard enough, but doing it while they're trying to navigate the long work hours, while they're caregiving, and all that economic stress, the inflationary factor has certainly taken a toll on people. So it just makes it all very difficult, much harder.
Yeah, much likely to be caregiving, right? You're much likely to have a multi-generational home, much likely to be caring for not just an older family member, but someone with a disability or someone with a substance abuse problem, or, there's a lot of care going on with people that are, struggling to carry on their own lives, have a job and take their kids to school. Travel, having a workable car, paying for the gas. I mean, a lot of people don't think about these things, and they are very real struggles that get in the way of people carrying out their medical care. So I love that you bring up those challenges. That was one of my questions. So I'll just say it again. The kind of health equity challenges that you're seeing for your community in the Los Angeles area, what would you say the top 5 are?
Well, I talked about one, which was the food desert issue, which leads to a lot of hypertension and diabetes. That is the highest chronic condition we see in our patients. Environmental health is also a big challenge in LA, especially because our neighborhoods are near freeways and industrial zones. We see high rates of asthma, pediatric asthma, and one of the things we've been working on for years is reducing ED utilization for kids with asthma, right? Unnecessary ED utilization or preventable ED utilization. But there's a lot of other respiratory conditions too, especially in the East LA and Westlake corridor where there's a lot of traffic and pollution. Another major barrier or another challenge is the barrier to care access that we talked about earlier. There's a huge shortage of primary care providers across the Los Angeles, and a lot of patients struggle with transportation and childcare, or just being able to take time off of work to go see a provider. Again, I always go back to my story when I was 18 and trying to go to my job and I couldn't be fired and I need to take time off to take my toddler to the doctor, and just how hard that was. And I had a situation where a provider said I was late by 8 minutes, so they couldn't see me, and it just crushed me, right? It was so meaningful to me and so not a big deal to them, but taking time off to work means you don't have income, and that rent comes due no matter what. So, we're always working to close these gaps. I think I only talked about 3, which was the food desert, the environmental issue, and the access to care. I could go on for days, but those are really the most prevalent ones that we're seeing in Los Angeles. We started a residency program the board of directors made a really courageous choice, I'll say, and kudos to my board, who is incredible and supportive and always thinking about the mission. But during the pandemic, we had such a hard time recruiting providers and keeping providers. That physician burnout was at an all-time high and the need for care was there. And I came into the board all impassioned, and I'll say at times I have my Pollyanna moments, like, we got to change the world, right? And I said to them, we're here talking about the workforce provider shortages, and, can I get you to agree that we should be part of the solution and train the next generation of physicians? And it was a little bit of a fight, but we got there. And on Monday, we just matched with our first 4 residents, which will be joining us in June. So I'm so proud of my board and all of the staff that made it happen, and eager to meet these 4 new residents that are the future of medicine. And I hope that we can keep them in the Los Angeles community, because it's tough. We're always working to close the gaps. We've started integrating nutrition counseling to help with, the hypertension, the diabetes. We do a lot of chronic disease education. I talked earlier about how we're constantly looking for culturally competent providers. You want your provider to look like you, right? To understand you. The challenges are systemic, though, and I don't have to tell you, it's super complex. None of these individual things are going to fix everything. It's not just about access to a doctor. It's about if people have the tools, the environment, the support they need to live well. Even when we offered telehealth, for example, we found that they didn't know how to get into the room, the virtual room. They didn't have internet connections that were strong enough to support them. So we had to shift into a model of teaching people how to use the internet. It was an interesting time, but we learned a lot about what we thought was the solution wasn't always the obvious solution.
Yeah, and it's a useful tool, but it requires more steps than just making it available.
That's right.
Which is, that's things you learn. Like, when I put together telehealth systems in the nation's biggest integrated healthcare system, we had to add telehealth clinical technicians to make it viable for people in their home. And so you add a technician that's able to help the person on the other end interface with the technology, because you don't want your providers doing tech support.
That's right.
A, it's not their area of expertise. B, they're going to give up too quickly. And C, it's not a valuable use of clinical time. But there are things you can put in place. So it's nice to hear that, people are learning along the way. I think telehealth just seemed too easy during the pandemic. They're like, oh, let's just turn it on. And I don't think it's not a viable, helpful thing. I think we're learning about what we need to have in place to support it, to make it work, including the Wi-Fi, right?
Yeah, I agree completely. I'll tell you a kind of funny story about telehealth. My parents, they speak English, but you have to work to understand, but they do their best. So my mom, in the pandemic, her provider was looking for ways to stay connected to her because she has some chronic conditions. And I went to visit her like I did every Sunday. And she was excitedly telling me that the provider had sent her this tablet so that she could join the calls, right? And I said, well, Mom, where's the tablet? She says, well, I couldn't figure out how to connect it, so I have it over there. She was using it as like a pot holder, like a plant holder. And I love my mom so much, but it illustrated, right? She tried, she couldn't figure it out. And the tablet became, a fixture in her home. But that scenario actually made me come back to Gracelight, and we did training for our community health workers in that tech support capacity that you talked about how exactly. And we started sending people out into the field to teach them how to do it where they were. So meeting them where they were, teaching them about the internet. It's a funny story, but my personal experience, highlighted some things that wouldn't have occurred to me.
Yeah. And it's a very worthwhile investment, because once they're connected, telehealth really changes the dynamic where the physician is in the room, in the patient's home now. A whole different dynamic, not one that is very heavily weighted towards the physician side of the power dynamic, right? It's much more equitable and equivalent, and a much greater awareness of what those social determinants of health are, because now you're in the patient's home. So it's very cool. Well, Eloisa, I think we're going to take a minute so that you can grab some water. You have been awesome. I'm really enjoying this conversation. We're going to come back and continue our conversation.